Good afternoon. Welcome to the lunchtime symposium from the Medicontur. This session, we are going to be talking about the applications of multifocal evidence in your clinical practice. My name is Professor Sathish Srinivasan from Scotland. Delighted to introduce my co-speakers, Dr. Joaquín Fernández from Spain and Dr. Guadalupe Cervantes from Mexico City. The first speaker will be Dr. Fernández. He's going to be talking to us about the cutting edge for presbyopia-correcting IOLs. Okay.
Thank you very much for the invitation, Sathish. It's an honor. And thank you very much, of course, to Medicontur, specifically to Alexandra for the invitation. Well, the idea is to talk about the cutting edge for presbyopia correction in intraocular lenses. So right now we can see exactly what could be the hypercircular and evidence around premium lenses. More or less, this is the curve of the acquisition of innovation for the doctors. And at the bottom, we can see the accommodation lens, the accommodation restoring is really now is not appropriate, okay? Then in the top, the peak of inflated implantation probably could be right now with the monofocal head-off lenses. We don't have right now enough clinical evidence. We also have the head-off lenses in a throw of disillusionment, probably because we have a few and short-term clinical evidence. And on the other hand, we have the trifocal lenses with numerous and long-term clinical evidence with a plateau of productivity. We have here all the lenses, at least in Europe, with the different families, the bifocal, trifocal, head-off, monofocal, head-off, and even the monofocal. Currently at September of 2020, we can see that the head-off has generally shown a monocular distant, not corrected vision of near of around 0.3 logMAR at 50 centimeters. In the monofocal head-off lenses, it should be demonstrated that we could have clinical advantages versus monofocal. With the bifocal lenses, with a short addition, it could be an alternative to trifocal lenses to slightly improve intermediate vision, maintaining a good near vision. And for sure, trifocal lenses could be the gold standard for covering several distances. We can see here our paper talking about Liberty and another group. You can see an excellent vision for distance, for intermediate, and for near. It's exactly the same in our paper than in other groups, so it's very predictability the outcomes of the lenses. We can see from present to future. We published recently in journal Refractive Surgery a model of prediction of visual acuity and contrast sensitivity for the Liberty based on optical simulation. And we can know the mean population visual performance with the Liberty for different pupil diameter, with metric easily, as you can see, understood by the surgeons. Of course, we are going to have developed also a multifocal lens analysis, our application for measure the visual acuity, also for contrast sensitivity in different stratified protocol of age, pupil diameter, follow-up, shift consideration, and with or without distance correction. It's very interesting to know the clinical consideration with longitudinal chromatic aberration technology for different technology. For example, the head-off diffractive lenses could be affected, as you can see here, in this paper published by Alpha recently in 2019. We can see that the head-off profile of these lenses is a chromatic dependent. So if we put a red filter in the eyes of the patient, we can see that for near could reduce the visual acuity of this patient at least 3 lines. So it's very dependent of the chromatic aberration. So we need to take care of that. The visual performance decrease at near with this red filter, and we need to know. And we also know that, for example, for the Liberty, we don't have this problem of chromatic aberration for near, as you can see here. We are measuring the defocus curve in chromatic, in contrast sensitivity, but for each chromatic situation. Also, of course, the longitudinal chromatic aberration of 0.5 dioptries at a pentacular plane for far distance, you can see, could be a little affected, but we are going to have a positive shift at far distance for blue and negative for red. We are going to have less efficiency at far distance for blue and uniform for red and green, but the total area under the focus curve above 0.3 logMAR and the contrast sensitivity is excellent. So in conclusion, new multifocal lens classification do not replace of trifocal intraocular lenses, which remain the gold standard for premium multifocal lenses surgery. Evidence should continue growing in the plateau of productivity of trifocal intraocular lenses, focusing exactly in the patient characteristics, the needs of the patient, and also the long term. And Liberty has clinically shown a non-uniform response to color and near vision, which is a disadvantage of current chromatic aberration in different technologies.
Thank you, Joaquín. The next speaker is Dr. Cervantes. She's going to be talking about when to operate on our patients to get the maximum efficacy. Dr. Cervantes.
Good morning here in Mexico and good afternoon around Europe. It is my pleasure to participate with all these great speakers, and thank you to Alejandra and Medicontur for the invitation. I'm going to talk about some aspects to consider in order to maximize efficacy and safety in your cataract surgery. I do not have any financial interest. From the 12 commandments, I'm going to talk about 4 of them. It is important to choose your intraocular lens always based on scientific evidence. This is in the market around the world. So it is important for us to choose the best option based on knowledge. We have heard for many years about the importance of the ocular surface and dry eye, but we still do not pay all the attention that require. The quality of tear film is very important to achieve high-quality visual results. We need to manage and assess it to deliver excellent visual outcomes. Dry eye is responsible of some optical aberrations and inaccurate intraocular lens calculations. So to obtain patient satisfaction, 3 to 33% of patients with cataract have OSD, and the surgery may induce or worsen the dry eye. Dr. Chuang in 2017 published an interesting paper about optimization of the ocular surface before surgery, and he divided into 3 areas. The first one is a preoperative assessment, and he says we have to identify and treat the patients. During surgery, it is important to reduce the surgical time, the microscope light exposure, and reduce the incision, among others. And in the postoperative, it's important to And in the postoperative, it is important to evaluate, give treatment, taper the treatment, and follow up the patients. This review has been done by Dr. Ko, and he discusses our past and current understanding of the visual disturbances in dry eye and the various tools available for assessing the visual function and the optical quality. These are maps of sequential waveform, as you can see, and high-order aberrations and simulated retinal images. In the normal eye, that is the group A, between one blink and the next, the visual performance is stable throughout after the blink. In group B, with the patient with dry eye, the retina image is normal, but it deteriorates as tear film stability decreases. This is when patients complain about blurred vision. And in group C, when the patient has dry eye and PRK, the retina imaging is affected right after blinking and remains poor until the following blink, as you can see right here in the graph. Starts bad and keeps on going bad, is very poor until the following blink. This is when the patient complains about fluctuating vision. Dry eye has a high prevalence after cataract surgery, is 5% 55.7%, and the key factors are tear film instability and OSD. Some of the visual complaints of dry eye will be glare and blurred vision, and also sometimes they complain about fluctuating vision with blinking. In conclusion, Dr. Sakatz, in his paper, showed that patients report visual functioning, dry eye symptoms, and health anxiety are much more closer to associated with patient post-op satisfaction than with the objective clinical measures of visual acuity or the signs of dry eye. I think this is a very, very important concept that we have to consider. Talking about astigmatism, Dr. Carones compared the impacts of induced astigmatism with 4 different types of multifocal intraocular lens. And when the amount of astigmatism added was between 0.25 and 0.75 diopter, satisfaction was high, as you can see in green, and moderate. But after adding 1 diopter or more, there was little or non-satisfaction, and we can see it in the orange and in the quality of vision. And before we go to the next slide, we have to correct keratometric astigmatism always that is higher than 1 diopter or 0.75, depending on the series that we study. Astigmatism management, it is important if we want to achieve good quality of vision and to perform a precise intraocular lens calculation. And we have to consider the total amount of corneal astigmatism. And as we can see in this graphic of MTF, how the MTF gets deterioration when the margin has just 0.25, as you can see here in the bottom. We just added 0.25 diopters of the focus, and the whole area of MTF has deteriorated. Astigmatism also may be associated with deterioration of visual function when conventional visual acuity of 20/20 is attained, but functional visual acuity testing seems to be useful in evaluating the mass astigmatism visual impairment. That cannot be detected by conventional visual acuity testing. On the graphic, we can see a study performed by Dr. Im in South Korea. He studied 132 patients, and he showed that Liberty provides very good visual acuity even when 1.5 diopter of astigmatism, as you can see here, was there. And we believe this is probably because of the neutral spherical aberration and depth of focus. Talking about pupil size, Dr. Joaquín Fernández recently reported visual MTF, the focus curves of visual acuity and contrast sensibility with different pupillary diameters from 2.5 to 4 millimeters, demonstrating that better performance is with smaller diameters as well as here. Okay, so in patients with multifocal intraocular lens, dysphotopsia increase, as we can see, with larger pupillary diameters. Several reports have shown that patient dissatisfaction due to large pupil size in different light conditions. It can be scotopic, mesoptic, or high mesoptic. During surgery, we cannot forget that pupil is very important, and we have to leave it very functional because the pupillary mydiosis do not stop with age, it just decrease the slight speed, as we can see in this paper recently reported. Before I finish, I would like to leave you some pearls to take home. We have to offer the patient real expectations, select always the multifocal based on scientific evidence. We have always to correct the high astigmatism higher than 0.75 or 1 diopter. And remember that OSD and dry eye may worsen with cataract surgery. And patient dissatisfaction, we can have it even with 20/20 visual acuity. Thank you very much for your attention.
Guadalupe, many thanks for that wonderful presentation. We'll go back to Dr. Fernández again. He's going to be talking about pearls to reduce dysphotopsias when implanting presbyopia-correcting IOLs. Okay.
Well, the idea is how could we reduce these photopsias without losing the near focus? Is this magic situation. Right now, all the market or the intraocular lens try to reduce the dysphotopsia, but losing this near focus with head-off lenses. But this is the only way. Could we do anything else? Well, we have right now the light-related discomfort in a professional perspective way, very well defined, okay? They are associated with light sources, and the street. But in the other hand, we have the patient perspective, okay? They say the lights bother me driving at night. They don't know exactly what is the difference between halo glare and Starbucks, okay? We propose to understanding this photopsia an approach of evaluation from the physical point of view in the optical vein with studies and also model side, in the psychophysical way with different parameters like the light distortion index and other, and in the psychometric way, also asking directly to the patient. The patient reported outcomes with questionnaires on simulator. But right now we are suggesting you define the positive dysphotopsia as any bothering. It's very important, the concept of bothering bright activities perceived by the patient along or around direct bright lights or reflected over object located in the visual field. Okay, if the patient is not bothered, is very important this concept, not bothered by the artifact, the term would be photic. We propose you the photic phenomena to use. So we differentiate the positive photopsia, bothering the patient, and the photic phenomena, not bothering the patient. With new approach, we develop an application in order to create some simulation on the patient and question, and we create this application to experiment the photic phenomena in the iPad in order to ask the patient the simulation parameter in order to show them the size, the intensity, and the halo width of the experiences. As you can see here, they can modify in the application all these parameters. We create that in patient operated with multifocal lenses and operated and not operated that are younger. And then when they create the simulation variable, they can answer to the question if that photic phenomenon bothered or not, and in what way. If not bothered, is photic phenomena you said, and dysphotopsia are bothered to them. And they can scale in a Likert scale in 5 levels, and then we ask them not only in one photic phenomenon, but also the bothered of the combination of all the photic phenomena, okay? And you can see here, when we asked them for that situation, the experimenting photic phenomena of the patient, it's only differences in the concept of the halo, when we compare multifocal with the control. When we, at the right hand, when we ask them about the simulation grade, only the intensity is a difference in the multifocal group with the control. In the other, the size and the width is not differentiated. And we don't find right now bothersome or the median of the bothersome in between the multifocal and the control. We are at the first beginning of the research, but this is more or less this concept. But as I told you, we are in a very early stage evaluating clinical dysphotopsia in order to take conclusions. So we are not able to take conclusion with this in research, this investigation, because we only could have information about the optical vein. For example, you can see here in this paper, we can take ideas of the PSF in the optical vein of different lenses. As you can see here, we can see different lenses, the technique, the symphony, the restor, and in between the profile of the PSF, you can see the different situation of the halo, the dysphotopsia. We can see here this halo, and we can see different type of glare, okay? And here you can see the profilometry in the PSF of the monofocal lens that you can see here the dysphotopsia is reduced in comparison with the other lenses, multifocal lenses. So we also know for different type of publication that the light distortion index, when we compare some EDOF lenses like Symphony with other trifocal, the light distortion index is not quite different. So probably the EDOF lenses right now is not giving us less dysphotopsia that we could expect because of the profilometry of the lens. And we also could have idea of the situation of these lenses. We can see here a monofocal lens, a Restor plus 2.5, and a Technics, creating these mobile model eyes that we can see with a camera more or less what could be the dysphotopsia of this type of lenses in a real situation, okay? And why 7 ring with Liberty? Well, you can see the differences in between the Restor plus 2.5 and another multifocal lens. This Restor 2.5 has 3.6 millimeter of diffractive lens, and you can see an apodization. This behavior is very interesting of the Restor 2.5, but the apodization will probably reduce the dysphotopsia, but for sure is going to reduce also the distribution of the near focus, okay? When we have here the Liberty is only 3 millimeters, and it doesn't have any apodization. So we are going to have an excellent distribution for near, and we are going to have exactly the range that we couldn't need. But this is a good question. Is it exactly this 3 millimeter? But first of all, let's see, and this CMAS Optic Studio with the different lenses, or the different trifocal lenses that you can see here, Liberty, Panoptic, Fine Vision, and Elisa 3. And for far, you can see that the halo, the dysphotopsia, is the near focus, the focused for distance, as you can see here. For the other trifocal lenses, you can see here that this sound that appears in the far distances with the near focus. But with the Liberty, you can see that the halo, the dysphotopsias, is quite reduced in comparison with the others. You can see here with the CMAS Optic Studio simulation, okay? And why this 7 ring? Of course, this is the concept. We can compare Fine Vision, Lisa 3, and Liberty. This diffractive profile is in the whole of the lens. When we have only 7 ring, we have this situation for far distance. We have an excellent focus for distance, but the near focus is not making us sound, it's not making us dysphotopsias, and you can see here. And as Lupe told us before, the question, the answer to the question, is enough 7 ring, is absolutely enough. As you can see in this paper that we are expecting to be published in the Journal of Refractive Surgery, is publication pending, because when we see the pupil of our patient in different ages, you can see that the 96% in the reading condition is photopic, and 96% of the pupil of our patient is less than 3.5 millimeter. In night condition, in mesopic, 83% is less than 5 millimeters, is in night driving condition. And in situation in photopic with low light condition, the 85% is less than 4 millimeters, excuse me. And you can see here that in this condition, the behavior in terms of visual acuity and the theoretical performance and also the clinical performance is absolutely excellent for even for the 4 millimeters, for the near, the focus curve, and of course, it's absolutely excellent for the distant and good enough in the intermediate for very high level of pupil we can see here. So in conclusion, we suggest to differentiate the photic phenomena in one hand for the positive dysphotopsia in the other hand, if the patient is bothered by design, reduce the positive or rings as much as enough to maintain near vision. In low condition vision level is good enough 7 ring. Our patient maintain a monocular visual acuity mean of 0.2 logMAR in low photopic conditions is absolutely excellent for this type. Is excellent balance. The rings, the number of rings with the pupil of all our patients, and the individual interpretation of performance with pupil diameter is now possible with Liberty, so just taking decision based on evidence. Thank you very much for your attention.
Thank you, Joaquín. So the final part of this symposium would be delivered by me. I'll be talking to you about what are the absolute red lines for implanting presbyopia-correcting intraocular lenses. So given the 10 minutes for the talk, I've just crystallized the topics into these five subcategories. We'll briefly look at the personality, patient expectations, and then coming on to the clinical examination. The three important areas which I'm going to concentrate would be the ocular surface and look at the absolute contraindications in the cornea, and then the contraindications in the posterior segment, particularly with respect to retinal and macular diseases. I think before we examine the patient's personality and expectations play a very big role in deciding whether there are any alarm bells or red flags which would contraindicate us as surgeons for using any type of presbyopia-correcting intraocular lenses. In my experience, I feel patients who are very pedantic and who wear glasses or contact lenses for very low refractive errors like 0.5 diopters of sphere would be very, very demanding on their visual needs. And I think in my experience, these patients would be not very good candidates as they would be very, very hypercritical of any kind of dysphotopsias or any minor ocular aberrations following implantations of presbyopia-correcting intraocular lenses with their very subjective view on these. Also be beware on low myopes. These patients have excellent optical quality for near vision, which is very difficult to reproduce with any kind of presbyopia-correcting intraocular lenses. So these patients need very detailed consent and discussion regarding the quality of vision, particularly for near vision and intermediate vision. Also avoid patients who have got very unrealistic expectations. I often say any of these technologies will only reduce the dependency on glasses, but it's not going to completely eliminate them. We also need to educate patients regarding contrast, external lighting conditions, and also the size of the print when they read, especially when it comes to near vision. So personality and expectations play a very big role, and I think as surgeons we will get a good feel for it when we speak to them, and if they're going to fill in any questionnaires saying what they expect out of presbyopia-correcting lenses. These can be very useful and give very good indications or clues for us to see whether one would be a good candidate or not. Then coming to the ocular surface, I think needless to say, as covered by my previous speaker, examination of the ocular surface and particularly examination of the tear film becomes extremely critical when considering patients with presbyopia-correcting intraocular lenses surgery. Both we need a subjective as well as an objective examination. Now, a lot of the ocular surface tear film. One of the devices which is shown in the slide is the HD analyzer from Vision Matrix, which gives us a very objective, real-time information on the tear film breakup time and also the ocular surface scatter, which would give us a lot of information regarding the quality of the tear film. And if we find these patients have poor quality of tear film, it's very important that we spend a lot of time optimizing the tear film before we embark on any surgical procedures. There are also other devices called Lacry Diag from a French company, which will help us to objectively analyze the meibomian glands and also the tear film quality, which will once again help us to guide any treatment or also help us to avoid patients for these kind of surgery. As I said before, both subjective and objective evaluation is required. There are no tools which will supplement clinical examination. So a good clinical examination, either with Lissamin green or with fluorescein dye, to look at the quality of the tear film breakup time, and also look at the corneal staining patterns. If patients have got very poor tear film or very severe dry eye or very severe corneal staining as shown in the slide, in my practice, these are all absolute red flags for implanting presbyopia IOLs. Also, we need to subjectively look at higher order aberrations. All patients in my practice for presbyopia-correcting IOLs undergo corneal topography and tomography. Irregular corneal astigmatism would be a red flag in my practice for considering presbyopia-correcting IOLs. Also, look at the higher order aberrations of the cornea. If patients have got coma of more than 0.32 microns, these patients have got a lot of distortions, and these would be poor candidates for IOLs, for presbyopia-correcting IOLs. This is just an example of a patient of mine who had a NIDAC OPD scan. The patient on the left has got very poor cylinder, but very low cylinder, but he has got very high significant coma and very increased overall higher order aberrations, which in my hands would be a poor candidate, in contrast to the patient on the right who has got low coma and low cylinder and low higher order aberrations, which would be a very good candidate. So I think it's very important that all these patients undergo good corneal topography and tomography, and to have a very critical view on looking at the higher order aberrations of these patients, in addition to the tear film, to see if there are any absolute red flags which would stop you from using these lenses. Also, Placido-based topography plays a very important role. This is a Placido-based topography from the Zeiss Atlas, showing a very nice bow tie with the rule corneal astigmatism, which would be very good candidates, in addition to a pentacam view of another patient, which shows marked inferior corneal steepening and also a crop claw appearance showing high irregular astigmatism. In my view, these patients will not do well with any kind of presbyopia-correcting intraocular lenses. So if you're picking patients, make sure they've got a good ocular surface and also have got good regular corneal astigmatism. Then we go on to the posterior segment examination. Once again, all my patients undergo routine preoperative OCT examination, which helps us to look for a lot of subtle or any subclinical macular changes. Any previous macular hole surgery would be a red flag. Any presence of epiretinal membrane would be a red flag, and also quite advanced glaucoma with a lot of nerve fiber layer loss and advanced cupping. These patients have markedly reduced contrast because of glaucoma, and on the top of it, if you're going to use any presbyopia-correcting IOLs, there will be a considerable loss of contrast as well as reduced subjective vision. So in my practice, I will not implant any presbyopia-correcting IOLs if patients have any of these pre-existing macular pathology. This is an example to show presence of an don't show any fluid intraretinally if they have large confluent soft and hard drusen, which can sometimes lead to drusenoid changes, especially in the subfoveal area, as shown in this picture where a patient has got a subfoveal pigment epithelial detachment. These patients don't do very well, and if they progress on to develop wet AMD, then they'll have a considerable loss of contrast as well as distortion of vision. So I think this is the end of my slide. So make sure these patients match their expectations, look at their personality, intraocular lenses. Thank you for your attention. That concludes our lunchtime Medicontur Symposium, and the final talk would have been from Dr. Harrisberg, who would who would have spoken to you about the reversibility of multifocality. Thank you for your attention.
Thank you for attending today. My name is Dr. Brian Harrisberg from Sydney, Australia. I'm a cataract and refractive surgeon interested in multifocal implants, and this talk is about the multifocal platform. There's a delay. If we look at why people want multifocals, it's purely because of demand. Patients are getting more sophisticated and have higher expectations, requesting spectacle independence. The best place for a multifocal lens is always in the bag, but perhaps, and this is my question, is it sometimes useful to have the multifocal component outside the bag to allow reversibility. If we look at absolute contraindications for implantation of multifocals in general, it relates to the optical media and associated retinal diseases, as well as abnormal pupils or amblyopia. In all these instances, we would prefer to avoid multifocal lenses. Laser operations in the past, chronic inflammatory disease, glaucoma, but in particular zonular instability, which can lead to tilted discs, and macular diseases in the future, which would limit the function of the eye. Of course, occupational expectations of the patient is a relative contraindication. The common reason some patients are not comfortable with the multifocal lenses is usually due to failure to neuroadapt after surgery. There may be an expected significant mismatch between the patient's expectations and intraocular lens technology offered. Poor immediate outcomes are based on residual refractive error. The key with multifocal lenses is to get the spherical equivalent as close to zero. Challenges determining preferred working distance for the patients may also interfere in success of multifocals, and late development of associated eye disease will also limit the function of the eye. A niche group of patients looking for multifocal flexibility are those who are not sure how they're going to cope with multifocal lenses, and they don't want to lose an opportunity to get an option of glasses independence. In this case, the dual procedure where the multifocal is outside the bag and all the power of visual correction is in the bag serves as a get out of jail card. And this could compare to using glasses or not. The ideal trifocal that I use is the Medicontur, and it is a hydrophilic acrylic with C-loops. The most important part is 7 apodized diffractive rings in the central 3 mm zone, but 75% of the intraocular lens surface remains refractive. If we look at contrast sensitivity, comparing this to a monofocal, the multi and monofocal have very similar contrast sensitivity decay. And if we look at the Liberty trifocal across all the other trifocals on the market, we see similar statistics. This Liberty is a diffractive lens, and there is about 11% loss of light, has a high Abbey number and 7 rings, which differs slightly to all the others on the market. And indication for a monofocal toric Medicontur is usually when we have regular corneal astigmatism, and I usually use the Barrett TK calculator with the IOL Master 700. When we use the dual lens implantation, I use that same monofocal described before in the bag, either as a toric or a sphere, and I have a plano multifocal component outside the bag in the ciliary sulcus. The specific design for this lens is a 6 rings of refractive power in the 3 mm zone and providing adds of plus 1.5 and plus 3 diopters. The anatomical requirements for implantation of an add-on lens into the sulcus in a dual lens setting is dependent on having an adequate pupil greater than 2.5 millimeters and a chamber depth of at least 2.95 millimeters in the phakic situation. It is essential to have good zonular support. Relative contraindications would be what we've described: keratoconus, glaucoma, spherical aberrations greater than 0.5 microns in a 6 millimeter pupil, phorias, tropias, planned monocular surgery in young patients, and again, zonular weakness or large angle alpha or kappa. The beauty of the add-on lens design and minimal ciliary inflammation. The point is this lens will be stable, and if it's a toric, will be able to maintain its position when compared to other C-loop lenses on the market. The key with any dual lens system is to have adequate space between the two lenses to avoid interlenticular opacification. And this is demonstrated in this slide of at least 0.5 millimeters of separation. The endothelial cell loss is not continual over a period of time, and post-operatively, these cells are maintained. And once this operation is complete, we then enlarge the wound to 2.4 millimeters. Viscoelastic is discretely placed into the sulcus and anterior chamber. The lens is loaded and lead haptics are delivered into the sulcus and rotated. The viscoelastic must be removed thoroughly, and myocol is used to make sure that all haptics are under the iris. The injector system is the Medicell injector, and we can see here, this video demonstrates the technique of loading the lens. All 4 haptics must be placed underneath the wings and secured. As the wings are closed, there's pressure down on the optic to allow adequate closure. This will be checked under the microscope. The plunger is advanced forward and retracted to make sure there's no catching of the trailing haptics. We did a study of comparing multifocal torics in the bag as well as multifocals in the bag versus the dual lenses, where we have monofocals in the bag and the multifocal component outside the bag. We looked at 72 eyes of 43 patients divided into the 3 groups I've described. They all had standard workup. We're using the TK formula with Barrett and the Zeiss IOLmaster 700. All the markings are done with the Callisto digital imaging system, and cataract surgery is done by one surgeon and was standardized. We compared uncorrected visual acuity, best corrected visual acuity, and spherical equivalent, and compared this data. The pre-op study of the different cohorts showed similar age, sex, preoperative biometry, and preoperative refractive characteristics. Perhaps there was a slant towards more males in the dual lens group, and there's no particular reason for that. Post-operatively, the distance visual acuity was similar across the board with outstanding results, with 90% or more achieving 6.7.5 in each eye. Again, if we look at the detail of the dual lens system, this was a great surprise and happy moment for me to demonstrate that there's no difference in the distance visual acuity between the systems of multifocals in the sulcus versus multifocals in the bag. We looked at the near visual acuity, and again, there was excellent results across the board in the 3 cohorts. Patients within 0.7 diopters of spherical equivalent and cylinder correction. This slide demonstrates the spherical equivalent almost within 0.05 in each eye and in each cohort. The rates of dysphotopsias were equal. There was no significant changes. Obviously, all these multifocal patients have some degree of glare and halo, and they were reported as not bothersome on questionnaires. At the 3-month visit, the questionnaires were directed to all 3 groups that we were able to continue following up, and again, there was no significant difference. Obviously, halos and glare are the standout, but they were only graded as 2 out of 5, suggesting that this is a minor difficulty for these patients. If we look at the satisfaction for visual function and lifestyle, again, the only issues that manifest as mild are driving at night. When we consider cataract surgery, we are obliged to inform our patients as to what all the options are. Since I've been introducing these dual procedures, I now have a detailed consent talking about how we aim for distance as monofocals, or we have multifocals, and should we have multifocals with dual lens systems or multifocals in the bag. The reversibility option of dual lens system is attractive to some patients who are unsure. Monovision is also discussed as part of the workup. We also go through the fact that if we do not achieve adequate refractive outcomes after surgery, we need to top up with laser as an option for visual correction. This is an interview with my patient who was the first dual lens that I implanted.
Now, Patrick, how are your eyes working at the moment?
Perfectly.
Are you happy with the outcome?
I'm very happy.
And what can or can't you do without glasses?
I can do everything without glasses.
Fantastic.
I've not had any problem at all.
And before you used to wear glasses for distance and
For everything.
near?
Yes.
So this is a big change in your life?
Yes. I will admit that when it was all first explained to me, I was a little bit dubious. And then it was explained that if there were any side effects, that it could be reversed very simply. So I thought, go for it. And I'd advise anyone else to do the same.
Yeah. And so, interestingly, most of your friends don't have multifocal implants, and they're all wearing glasses after cataract surgery.
Yes.
And what have their surprise been?
Well, when I've explained to people what happened, they said, oh, but I've never heard of that before.
Yeah.
People just don't know about it.
Yeah. Excellent.
Thank you for your attention.